Hi, my name is Ben Westphalen. I'm ESMO's Precision Oncology Task Force Chair, and I'm here with Christophe Tourneau, a real champion in precision oncology from Paris, France. And today we would like to discuss molecular tumor boards in clinical practice. Since molecular tumor boards have moved from translational research platforms, from research entities close to patient care, fully integrated into clinical care pathways, it is important that we have some standards, some general directions for practitioners, for clinicians on how to implement them into clinical care. Not as strict rules that have to be applied globally, but rather as guidance on how to build a molecular tumor board in any given region.
There have been several initiatives trying to standardize the way we run molecular tumor boards, coming especially from Europe. The first one is the initiative by the ESMO Precision Medicine Group led by Benedikt here, and that was published in Annals of Oncology last year. The second initiative was an initiative led by the Can Hill Consortium, which is a European consortium on precision medicine as well. And they also established some guidance on how to run molecular tumor boards, and that was published in the European Journal of Cancer.
The current recommendations on how to run molecular tumor boards in clinical practice cover a wide range of topics. I want to highlight that we've covered what patients should be included, not to exclude patients, but what is the goal to facilitate molecular tumor board discussion with a maximum benefit for the individual patient at task. We've spoken about the composition of a molecular tumor board. We've discussed questions of data collection and follow-up. Again, there are several pieces to the puzzle that you can take and choose and build your own molecular tumor board. As we said, those are not strict recommendations that need to be followed through. They need to be adapted to local requirements.
So there are several indicators that we can use to assess the quality of molecular tumor boards. The first indicator is the turnaround time to get the results. The second one is in which proportion of cases we really get a result and not like a failure of the experiment or the assays that have been used. And then on the clinical level, one indicator is the proportion of patients who were eventually treated with match therapy depending on the molecular alterations that were discovered during the molecular tumor board. And I would say the last indicator that is also important is the volume. MTBs that only discuss a few cases is probably not enough. So it needs to have a substantial number of patients to be discussed in these molecular tumor boards to be sure that the quality is there.
In order to implement the recommendations that Christophe and I have discussed, I believe it's important to educate our colleagues across the world why we believe it is important that we have certain standards in molecular tumor boards. As mentioned, I believe molecular tumor boards are now part of clinical care, so we should have the same rigor and the same quality indicators that we use in other settings of tumor boards. So explaining this to the community, doing education, putting out recommendations, running webinars, this is important to educate our community, and then the pickup will solve itself in the end.
We need some flexibility in how we run molecular tumor boards. First, because there are differences across countries, especially in terms of legislations, but also across centers, because the way things are being done may vary across these different centers. What is key at the end is when running this kind of molecular tumor board is to have access to drugs. And obviously it's more interesting for patients to have molecular tumor boards or their cases discussed in molecular tumor boards in centers or areas where they can access drugs, especially in the context of clinical trials.